before I dive into a few other questions, could you take me through a bit of this recent published article that you guys have in diabetes care?
Sure,
I know it's
sure.
a bit of a different look at data. A lot of things that we've seen related to hyperglycemia, diabetes, and COVID-19 has sort of been retrospective looks at data from even outside in other hospital systems. But this is
Mhm.
a bit different. Could you take us through the study and sort of what you
Yeah,
guys?
so this was our experience at University of Michigan or Michigan Medicine, which is our health system. And it was an interesting experience as obviously when the pandemic hit, and it's particularly here in Michigan, we started the lockdown in March and we had pretty much a peak between March and April. And very soon it became apparent that patients who are admitted with severe COVID disease, particularly if they had diabetes, they had a very severe course of disease, which was further further worsened by extremely extremely large glycemic excursion, so a hyperglycemia, which was really very hard to treat. In addition, at that time, we were facing additional challenges, including preserving protective equipment, how to make sure that the staff and the providers that are taking care of these patients do not spend unnecessary time in those rules. Because in theory, when someone comes with very high blood glucose in the hospital, we have, established protocols, which many of them require administering insulin as IV infusions. In fact, our health system has been at the forefront of pioneering an inpatient management of hyperglycemia that my colleague, who is also the first author on this paper, Dr. Roma Chandani, had been directed for more than 15 years now. So we do have established protocol. In fact, we have a team, many of whom are authors on this paper, that have provided excellent care. But in this particular instance, administering IV insulin wasn't feasible because those require hourly insulin adjustments, and clearly to preserve negative pressure in those rooms, to preserve PPE, to not make the nurses go in the room so often. We couldn't do that other in very, very select cases that couldn't respond otherwise. So that's why we basically learn as we, on the run, and developed other protocols to use, sub-Q insulin that can be titrated at 4 hours interval. But because of that, our team had to basically work nonstop. So we partner with the ICU and all these services where these patients have been admitted. And our team then was in charge on inpatient management of hyperglycemia, writing orders. We were writing orders every 4 hours, rechanging the insulin dosing, tracing this very severe glucose excursion, and that's our perspective. Eventually, of course, again, that was such an interesting learning experience. We have also realized that there are additional markers that we can use, including some of these inflammatory markers, that people who had more severe inflammation developed the highest insulin resistance, and they were the most difficult to treat. So that has allowed us to use some of this marker in our decision making in these protocols. Yes, it's true. This is a perspective, and we only presented some summary of data in this initial paper. But we do have we have been monitoring these people, and we are now preparing additional communications and other outcomes in this cohort.
Okay, thank you for that. And now the onus behind developing an algorithm for these patients is pretty obvious. How helpful do you think it's been for clinicians at Michigan Medicine to sort of have this algorithm in place? Because I know a lot of places have
It
been.
was extremely helpful. And I know that we couldn't say too much in a manuscript due to all kind of restrictions, but in fact, the fact that we were able to unload all this glucose control management from the ICU physicians and nurses was extremely well received because they didn't have to worry about one aspect and they could concentrate on, you know, kidney function and respiratory function and all these other measures that were being undertaken to take care of these patients. Because as you know, also, particularly those with diabetes, the proportion developing, you know, severe kidney dysfunction was very high. The proportion of people requiring to be on ventilator was very high for patients with diabetes, and that is actually true across the world, and particularly here in US. But if you look at the data from the entire New York City health system, the Europeans, the French, and the Italian experience, the Chinese, so everywhere the outcomes in patients with diabetes are much more severe, and that was exactly what we observed here. But we have received and continue to receive so much appreciation for the fact that this aspect, which was not trivial, because, you know, the higher the glucose also, the much worse the rest of the outcome have been and could have been if we wouldn't have moved so quickly to identify a way to bring this down effectively. So I think that I'd like to commend our team, but also the entire team within Michigan Medicine, because we, after the initial couple of weeks when everybody was still learning and we were trying to understand what's happening, I think that we developed this working protocol that in the end helped so many people to survive and be discharged.